So diaper dermatitis is a common skin condition. It is characterized by a compromise of the barrier function of the skin. Skin works as a barrier. The skin has to be intact, has to be integral, has to have, it has a protective effect in the body. What happens in diaper dermatitis is the skin loses this kind of barrier function. There are several types of diaper dermatitis. The most common type of diaper dermatitis is irritant diaper dermatitis. And the second common type is what we call Candida diaper dermatitis. There are also different types or other types such as allergic diaper dermatitis. So here we'll talk mainly about the two that we commonly see in the pharmacy, which are the irritant diaper dermatitis and the Candida diaper dermatitis. So let's start first with the irritant diaper dermatitis. This is the most common cause of diaper dermatitis. It's commonly referred to, diaper rash. That's when people will come to you in the pharmacy saying that my son has diaper rash. Common symptoms of the irritant dermatitis, which is the diaper rash, include erythema, dryness, mild scales, shiny skin with severe redness sometimes, with or without papules, vesicles, oozing, and ulceration. This is usually in the severe form of the disease. The child even may be asymptomatic. Asymptomatic here means the child doesn't have a problem, doesn't feel it, doesn't feel like fussy or doesn't cry or anything like that. Diaper dermatitis, and here we're talking about the child. Um, it can be, also affect elderly who have incontinence. So this is not only limited to children. Diaper dermatitis affects the external surface of the buttock and genitalia, and it spares the inguinal folds. That's one of the important differences between diaper dermatitis and candida diaper dermatitis. The folds in the inguinal region, in the genital region, the folds, the body folds, when you have a baby and the baby is a little bit choppy, and there are folds in the inguinal region. If you try to open gently these folds in in irritant diaper dermatitis, the folds are clean. In Candida, you may find spots inside the folds. That's an important differentiation point between irritant diaper dermatitis and Candida diaper dermatitis. Diaper dermatitis, the irritant one, is more common in adults than in infants. And if it's not treated properly, the irritant type diaper dermatitis, if it's not treated properly, it may progress to ulceration, and it also can be associated with vulvar and penile infection. So this is the irritant type of the diaper dermatitis. The second most common type of diaper dermatitis is Candida diaper dermatitis. Candida diaper dermatitis, um, the symptoms are usually beefy red rash. Mothers usually come complaining that the skin is like tomato red, very, very red. There is preanal skin maceration. There are satellite papules, so the spots or the red spots are scattered. Usually in the irritant diaper dermatitis, it's one large area. If it's severe, it becomes tomato red skin, and we will start to see, or the mother will start to see papules, pustules, and peripheral scales. And also, it involves the inguinal fold. Now, let's talk about a couple of things that are important here. If a mother comes to you in the pharmacy asking for something for diaper rash, how can we differentiate between irritant diaper dermatitis just because of the usual use of the diaper or candida diaper dermatitis? These are three important questions. There are questions that are very important to ask. Number one, the skin color. In the candida diaper dermatitis, the mother will describe the skin as being beefy red, or you even can ask the question, can you say that the skin is too red, like it looks like beefy red or tomato red? If the answer is yes, this can be candida. That's question number one. Question number two, do you see for the whole area, the outermost layer of the area, so the whole area from the outside, do you see kind of scaly borders? So there are small scales all over the outermost layer of the area. If there are this kind of scaly border, this also can be Candida diaper dermatitis. Question number three, if you gently open the inguinal fold, do you see any kind of satellite red patches there? If yes, this is also most likely Candida diaper dermatitis. And the last one is these kind of satellite lesions. So in diaper rash, it's one large um, area, but sometimes in the Candida, you will find the large area affected, and you will find outside some scattered satellite papules. So this is how you can differentiate between Candida diaper dermatitis and irritant diaper dermatitis. Scaly borders, the color of the skin, beefy red or tomato red, the presence of these, satellite papules, and finally, the inguinal fold is involved. Like there are some spots or some lesions in the inguinal fold. So now let's talk about the risk factors for diaper dermatitis. And the answer for this question is C. As we mentioned previously, the main problem in diaper dermatitis is deterioration of the skin barrier function. The risk factors listed in this question all contribute to either decreasing the skin barrier function or to cause irritation. Of course, except C. C is not a risk factor. High sugar diet is not a risk factor. Let's see how A, B, D, and E can be risk factors. So remember, the problem is deterioration in the barrier function of the skin. So all the risk factors will either reduce the barrier function of the skin or cause irritation. Let's take them kind of one by one. So malnutrition can affect the skin integrity and it can weaken the skin barrier system. That's the malnutrition. Incontinence, which is a choice B, stool and urine are irritant to the skin. High protein diet, which is choice D. High protein diet increase the amount of the ammonia removed in the urine, and ammonia is very irritant to the skin. Bottle feeding. Bottle feeding is a risk factor because it makes the stool more irritating, alkaline, and copious. What does that mean? Copious means large amount of stool. So, and the stool becomes more irritating in bottle feeding. So actually, breastfeeding may even reduce the risk of diaper dermatitis. Here we'll talk about additional risk factors. So irritants such as soap, the ammonia in the urine, pancreatic enzymes, and bile salt in the feces, especially with diarrhea. So children who have diarrhea, there is more stool coming out. The stool may contain some pancreatic enzymes, may contain some bile salts, and these are very irritating. Friction, either skin to skin or skin diaper, and also vigorous cleaning. When the mother is cleaning, if she's a little bit aggressive, this can cause diaper rash. Antibiotic therapy increases the chance of skin colonization with candida. This is one of the risk factors specifically for the candida, not just for the diaper dermatitis, but mainly for the candida. The occlusion effect of the diaper. So mothers who are using the old school cotton diaper plus plastic occlusion, the occlusive effect is a risk factor. Ammonia and pancreatic lipase and bile salt, all of these factors will increase the skin pH. So the occlusion effect, the ammonia, the pancreatic lipase, the bile salt, all of these will increase the skin pH. And also, the occlusion effect causes skin maceration. The occlusion effect causes skin maceration. Prolonged wearing of the diaper, using the diaper for a long time, not changing the diaper frequently, or using the cotton diaper plus the plastic occlusion, this causes skin maceration. And skin maceration weakens the skin and also it increases the penetration of the fungus into other skin layers. Finally, the cow milk based formula that leads to the copious stool formation, more irritating stool, and alkaline stool. So these are um, different risk factors in addition to what we had on the previous slide. In addition to the risk factors we had on the previous slide, there is one more new risk factor that we need to also add, which is seborrheic dermatitis. Seborrheic dermatitis is a predisposing factor to diaper rash in infants. When should you refer the baby or the child or the person who has diaper rash to the physician? If there is no response to treatment after 1 week. So we can treat it OTC, it doesn't have to be diagnosed. But if there is no treatment, there's no response to the treatment for after 1 week, the patient should see the physician. Dermatitis doesn't heal after 7 to 10 days. So no response, or there is response, but by 10 days there is no healing. It's not completely, it didn't completely disappear. Also, having pus, blisters, pain, deep ulceration, or oozing. These are the specific questions you have to ask, the patient or the caregiver. Sudden onset. Usually, diaper rash develops slowly and gradually. It takes a few days, but if it happens right away, this is a concerning thing. Chronic, chronic or frequently occurring if they keep coming back. Systemic symptoms such as diarrhea, fever, vomiting, or if it's spreading to other areas, or having complications such as UTI, penile, or vulvar infection. Again, some people will say, well, how will we know if there is UTI or something like that? Remember, diaper rash is not limited to only infants. Diaper rash can also affect adults who have incontinence, patients who are immune deficient, and those who have symptoms associated with behavioral changes. So, for example, in children, they are excessively crying and they are so fussy and they can't sleep at night and stuff like that. This can also be a red flag. Now we'll look at the non-drug measures for the management of diaper rash. And the non-drug measures are closely related to the risk factors we mentioned before. So you will notice that we are just trying to kind of handle these risk factors and these triggers that can worsen diaper rash. So the first one we have is to keep the area dry. And this is by removing the diaper and to allow the area to be air dried for as long as possible. As we mentioned before, that candida flares when the area is moist or wet, and that's why we need to keep the area dried. So how do we do that? We remove the diaper and keep the area air exposed for as long as we can. We can do this during the cleansing. So after we finish cleaning the area, we keep the area exposed to the air to dry. Also, we can do this during the treatment. So after applying the treatment, we can keep the area exposed to dry. And when we change diaper, and it's important to advise the mother to not use hair dryer or infrared lamp. Some mothers, to quickly dry the skin, they may use hair dryer, and this is not a good idea. The second point we can do is to use diapers with absorbent cores and breathable outer cover. Most of the commercially available diaper these days will have this description. They absorb the urine and the moisture and they keep it inside the diaper, not in contact with the skin. And it's also important to avoid the old school cotton diaper, because when we use cotton diaper, the cotton diaper will hold the moisture and the urine and keep it in contact with the skin. And then the old school cotton diaper is also used with the plastic wrap. So, or plastic underwear. So we put the cotton diaper and then a plastic underwear on the top. This plastic cover provides an occlusion layer that actually traps the moisture inside, and this causes skin maceration. The third thing we can use is to use talc powder. Talc is anhydrous magnesium silicate. It is actually effective as lubricant and also to reduce friction between the skin and the diaper. One very important point when we educate mothers on using talc powder is to apply to the hand or a cotton ball and then dab it on the skin. So we will not apply it directly on the skin. We apply it first to hand or to a cotton ball and then we dab it on the skin. And this is important to avoid the inhalation of the very fine powder if we apply it directly on the skin. We also recommend to the mother to avoid using cornstarch. So some mothers may use cornstarch instead of that talc powder. Cornstarch may be effective in reducing friction, and also it can absorb moisture. But the problem is it is starch. So starch can actually increase candidiasis. Finally, we need to advise the mother to avoid baking soda, because baking soda, if it's applied to an area where the skin is not intact, it can cause metabolic alkalosis. And also, powders are less generally powders are less effective than paste. This is not only for baking soda, but this is in general for all the powders, and that's why the best thing we can use is usually zinc oxide paste. So we also may consider gently cleaning the area using soft cloth. Now, how we're going to clean the area depends on what we clean. So if we are cleaning just urine, we don't need to really wash. We can just rinse with water. That's enough. We don't need to use soap or anything like that. If we are cleaning stool, then we need to wash the area. We can wash the area using water and mild soap. We can use soapless cleanser, or we can use oil in water lotion. And after we wash the area, either rinsing for the urine or washing for the stool, we can pat or blot dry. We may also, instead of washing or gently cleaning the area with soft cloth, we may consider cleaning the area with diaper wipes. If we use diaper wipes, we must make sure that the diaper wipes are non-irritant, and they should be alcohol, soap, fragrance, and lanolin free. So now, which one is the best? Is the best to clean the area and wash the area with soft cloth, or to clean the area with diaper wipes? Actually, wipes are superior to washing the area with soap and soft cloth. Why the wipes are superior? Because the wipes are associated with less erythema, less dryness, and less skin roughness. Um, just we need to make sure when we use the wipes that we use them on intact skin, so we don't use the wipes on broken skin. Another thing we can do is to change diaper more frequently. And if we use cloth diaper, this is the old style diaper, when the diaper is cotton and then we put a plastic covering on the top, or plastic wrap on the top, we need to wash the cloth diaper with water and gentle soap. And we need to rinse them carefully to get rid of the chlorine. And we may consider adding vinegar to the final rinse, because vinegar will kill any kind of candida attached to the cloth diaper. And finally, we need to treat symptoms early. We don't need to wait too long before the symptoms get worse and the area starts to get infected before we treat the area. It's better to treat the area once we start to see any kind of redness. It's also important to avoid excessive washing of the area because excessive washing increases the dryness and increases the risk of infection. And that's why on the previous slide we said that diaper wipes are superior to washing. If the area is oozing or crusted, we can use compression. So how can we do compression? Compression is done by wetting a piece of gauze. So we get a piece of gauze and we make it wet, and then we apply it to the skin for 1 minute, and then we remove it for 1 minute, and then we reapply the gauze again, the wet gauze, for 1 minute, and then off for 1 minute. And we do this for about 20 to 30 minutes. So 20 to 30 minutes, 1 minute on, 1 minute off, and we repeat this 4 to 6 times per day. This helps to um, um, soften the skin and to remove the crust. We can also consider adding oatmeal to the soaking solution or to bath water if we give the child a bath. Oatmeal hydrate the skin and soften the skin. Finally, some mothers use something that's called double diapering. They use two diapers, one on the top of the other. Why would they do that? They do this to reduce the frequency of diaper change. So, for example, they're going outside and they don't want to change diaper when they're outside, so they apply two diapers, one on the top of the other. This kind of practice should be avoided. Now we'll talk about the management of diaper rash. So we have two approaches in the management. We have prevention and we have treatment. So first, let's talk about the prevention of diaper rash. Well, our target when we try to prevent diaper rash is to prevent the contact between the skin and the irritants. So we need to use something that prevents the skin from getting in contact with the urine and feces and stuff like that. And that's why the first choice that we use is barriers. So we use barriers as the first choice. They keep the irritants away from the skin, and they also reduce the friction between the skin and the diaper, and this allows the skin to heal. The barrier of the first choice is zinc oxide. So this is the preferred barrier, and it is the most effective. It has multiple effects. It's an antiseptic, it's an absorbent, so it absorbs the moisture that makes the area more susceptible to candida infection, and also it has astringent effect. We usually start the prevention with 15 to 20% zinc oxide. If this is not effective, we go to the 25 to 40%. And when we apply zinc oxide as a barrier, we need to apply it as a thick layer when needed. And usually, when we say when needed, this is usually when the baby urinates and we need to change the diaper, or if there is a stool and we need to change the diaper. That's when we usually apply another layer of zinc oxide. The onset is immediate, it works right away, and the duration is 3 hours. We have other agents that we can use as barriers, such as the dimethicone or the dimethyl polysiloxane, and they are less effective than the zinc oxide because they only work as water repellent. They are not absorbent and they are not astringent. We also apply them as a thick layer when needed, and they have the immediate effect and also duration of 3 hours. Vaseline can also be used as a water repellent, but as you know, Vaseline has occlusive effect. It prevents the evaporation of water from the skin, and this can cause skin maceration. The second approach we'll talk about is the treatment approach. And for the treatment approach, we have two problems that we'll treat. The first one is diaper dermatitis when there is no candida infection, and the second is candida dermatitis. So let's first start talking about treatment of diaper dermatitis. Again, diaper dermatitis is when there is no candida infection. How can I know that there's no candida infection? We discussed this before. When there are no symptoms of candida, so there is no scaly borders, there is no satellite white patches on the skin. The skin is not tomato red or beefy red, and there is no redness or inflammation going into the inguinal folds. So when we don't have any symptoms suggesting candida dermatitis, and we discussed these in details, then we have only diaper dermatitis. For diaper dermatitis, the first choice is 25% to 40% zinc oxide. This is for the treatment. Someone will say, okay, well, the 25% to 40% zinc oxide is also used here for the prevention. How can we do this? So now let's discuss this a little bit in details. Our first choice, of course, is to prevent diaper rash. So for the prevention, we give 15 to 20% zinc oxide. This is our first choice. So the mother should be using that. Okay. Now, while the mother is using the 15 to 20% zinc oxide for the prevention, the baby got diaper dermatitis. So while using the 15 to 20%, the baby still got one diaper dermatitis. For the treatment in this case, we will use 25 to 40. So we'll increase the strength of the zinc oxide for a week or so to treat the diaper dermatitis, and then we go back to the 15 to 20% for the prevention. Okay, now what happens if we notice that the 15 to 20% for the prevention is not effective, in the sense that every couple of weeks there is another episode of diaper dermatitis. So the mother keeps using the 25 to 40 for the treatment every couple of weeks. So this means that the 15 to 20% of zinc oxide is not very effective in prevention, and that's why the baby keeps getting diaper dermatitis. In this case, we will go to use the 25 to 30 to 40% zinc oxide for prevention. Okay, now when they are using the 25 to 40% for the prevention, what will we give if the child gets diaper dermatitis? So now this diaper dermatitis comes while using the 25 to 40%. In this case, if the child is 2 years of age, we can recommend hydrocortisone. If the child is less than 2 years of age, we need to refer this child to the physician because we already used the 25 to 40% zinc oxide for the prevention and it is not effective. That's why the child got diaper dermatitis. So we need something stronger. Now, there are a couple of new options for the treatment, or actually it's one new option, which is the topical human breast milk. The topical human breast milk, and that is true, the mother can take some breast milk and apply it to the affected area. It was found to be comparable to the zinc oxide 40% in the management of diaper dermatitis. And one study found that applying the human breast milk to the affected area for 1 week is as effective as 1% hydrocortisone. So for diaper dermatitis, our options are 25% to 40% zinc oxide, if the zinc oxide 25 to 40% is not used for prevention. If 25 to 40% zinc oxide is used for the prevention, we can use hydrocortisone, and we may recommend hydrocortisone if the baby is 2 years of age. Another option that we do have now is topical human breast milk. So this was the management of diaper dermatitis. Now let's look at the management of the candida dermatitis. So that's when the child has the classical symptoms of candida, the white scaly borders, the satellite white patches in the area. The skin is tomato red or beefy red, and the redness and the inflammation extends inside the inguinal body folds. In this case, of course, because we have candida, we need to use an antifungal. So we have topical clotrimazole or miconazole. These are the preferred agents. We need to rub them in the skin twice daily for 1 to 2 weeks. And it's important to remember that it's rubbing in the skin, not like zinc oxide when you apply a thick layer. So we rub them in the skin twice daily for 1 to 2 weeks. Sometimes we add menthol to reduce the pruritus, and also it reduces the healing time. We also may use nystatin. However, nystatin is not as effective as the azoles antifungal. So nystatin can be used. We rub it also in the skin 2 to 3 times daily for 2 weeks or more. So it is not as effective, and it usually needs longer duration of therapy. Cyclopyrox is more effective than nystatin, but it is less effective than the azoles. We rub it in the skin twice daily for 4 weeks or more, and it's approved for children 10 years and older, but it can be used under 10 years. There is no concern of safety, and cyclopyrox has some anti-inflammatory effect on the top of the antifungal effect. Sometimes when we are treating candida dermatitis, we need to add some hydrocortisone. 0.5 to 1% hydrocortisone can be used in children more than 2 years of age for 1 to 2 weeks. When do we use the hydrocortisone? If the area is severely inflamed. So hydrocortisone is not something we always use in candida dermatitis, but if there is severe inflammation, we may use hydrocortisone along with the antifungal to reduce the inflammation. And we need to apply thinly up to 3 times a day. And antifungal and the hydrocortisone can be used in combination, or they can be used alternatively to reduce dilution. What does that mean? We have to use both. In candida dermatitis, we cannot use hydrocortisone without the antifungal. We can use them together in the sense that we can mix them and apply them, or we can put the antifungal, the antifungal first and then the hydrocortisone. Like we can put one layer on the top of each other. But the point is, when you add one layer and then you add the other medication, you mix the two medications together, this can cause dilution of the strength of both medications. So our X files suggest to use them alternatively. What does that mean? You apply the antifungal, maybe 2 hours later you put the hydrocortisone, then maybe 2 hours later you put the antifungal. So you alternate the layers. And if the management using these measures, using the topical azoles and the hydrocortisone, with or without the hydrocortisone, if this continues to be ineffective, then we need to refer the child to the physician. What's the order of application? So as you can tell, we are using three major ingredients. We can use zinc oxide, or sometimes we can use zinc oxide with antifungal or with hydrocortisone. Like, how do we use them? Well, if you're using antifungal plus barrier, so the child has candida, so you are giving the patient, the child, antifungal, and also you can, on the top of the antifungal, you can apply the barrier. So, barrier is barrier. You can always use the barrier. So if you're using the antifungal plus the barrier, apply the antifungal first. Makes sense. You want the antifungal to be on the skin and the barrier to kind of seal on the top to prevent contact with the irritants. If using antifungal plus hydrocortisone, apply the hydrocortisone first. What if you are using all three? Baby who has severely inflamed, well, I don't want to say severely, so you think we have to refer, baby who have inflamed skin, so you want to give, and that has candida, so you want to give antifungal for the candida, you want to give hydrocortisone um, for the inflammation, and you want to give a barrier on the top to reduce friction. How will you apply all three? We will apply hydrocortisone first, then the antifungal, then the barrier is the outermost one. Very important to avoid scented products and lanolin containing preparations, as they may cause more irritation, and we should not apply them anyway to inflamed skin. So now let's have a question about oral um, nystatin. Why we need to talk about oral nystatin in diaper rash? Because it is common for children who have diaper rash, candida diaper dermatitis, to have also with the candida diaper dermatitis to have oral thrush. This is common, so that's why we're covering this topic here as well, how to manage oral thrush in children. And the answer for this question is C. Nystatin suspension does not require reconstitution and it is stable. So there is no problem, there is no time, there is no reconstitution, and there is no limit for how many days you can use it. How do we use nystatin oral suspension for oral thrush? The dose for pediatric, we apply 1 milliliter in the mouth 3 to 4 times daily. In the adults, we have to swish and swallow with 5 milliliters 4 times daily, usually for 2 weeks, plus for 2 days after the 2 weeks, after the symptoms completely disappear, just to make sure that there is no remaining fungus in the mouth. Before applying, we need to rinse the mouth. If it's an adult, they can rinse their mouth. If it's a baby, we can rinse their mouth with water. So we give them something to drink, or we can use damp cloth and just try to wipe the inside of their mouth. For adults, it's easy. You will give the 5 milliliter and you ask them to swish and swallow. But how can you get the baby to use it? So for the baby, we apply half cc in each cheek. We can put the medicine in a little spoon and or a little plastic cup like one of these measuring cups, and then we use a Q-tip, take a little bit of the medication on the Q-tip and swab in the baby's mouth, and there should be some improvement in 48 hours. It is very effective in oral thrush. Some non-drug measures for management of oral thrush: we need to boil any object that goes in the baby's mouth, such as the pump. If the mother is using pump, the piece that goes in the baby's mouth has to be boiled. Bottles has to be boiled, toys and pacifiers. We need to boil them for 20 minutes every day. And we can also add some vinegar to the boiling water because vinegar will also kill the fungus. And we need to treat the mother's nipple. This is commonly required in babies who have oral thrush. So you may find the mother coming and asking, like, why do I have to be treated? I don't have any symptoms. Why the doctor prescribed some antifungal for the nipple? Well, that's because the baby has oral thrush. And when the baby latch on the nipple to feed, the mother can get infected and she may not even see the infection. And then this can cause reinfection to the baby. The opposite also will happen. So if the mother has a nipple infection, nipple yeast infection, we also have to give the treatment to the baby, because the baby, when he latches to or she latches to the breast, the baby can also get infected.